CataractCoach.com. Capsule Rip in less than 1 second. This is how to successfully recover from this capsular rip. So here's a video of Willie Kant from Malaysia showing us a beautiful technique of using a needle to decompress these intumescent white cataracts. So entering there, decompressing it, taking out that intumescent fluid, and now a normal capsular rhexis can be completed. So that's how it should be done. But this case is going to be a little different. Let me show you our case. Now we zoom in here. Patient's about 30 years old, diabetic white cataract. And here's what's different. We filled the eye with viscoelastic, and if I touch, look how pressurized that anterior capsule is. This capsular bag is totally pressurized. Now, there's not a layer of fluid like we normally see here. Normally, you'd have an endonucleus that's solid, surrounded by intumescent fluid. But in this case, what we have is all of the fibers are swollen. So we're getting the eye pressure high. We hopefully want to have a very high pressure in the anterior chamber. We're going to poke in with the needle now and quickly aspirate. And let's see if we can achieve that same technique here. Now we just have that one incision. We poke in and boom. Oh my goodness. What has happened? Where's the fluid? All the fibers are swollen. Wow, it's still swollen. Let's look at 1/4 speed. As soon as that needle touches that lens capsule, it rips uncontrollably. That's how pressurized it was. That's tough. Let's look at 1/10 speed. Just as soon as it enters, it's done. You can't even control it. So what could we have done differently? Maybe used an alternate device to make a capsular opening? Buzz in with the phaco probe, use a femtosecond laser, use some other plasma cutting device. A lot of options here, but even those may not have worked. So now we'll go in here, cutting with the scissors, and we're going to try create the remainder of the capsular rhexis here. And you can see it still wants to run out. We're having to pull it in quite a bit just to help control it. So there we go. Now we want to make very careful, be very sure that we don't cause that rip on the capsule to extend to the posterior capsule, because that'll be an issue. Now the lens is soft. We're going with just the IA probe to aspirate the material out. Now, could we have placed the needle on the IA probe and then go in there aspirating? Yes, but you may have had the same issue because you may not have been able to decompress that lens fast enough to prevent that capsule rip, which happened in much less than 1 second. So all the lens material comes out pretty easily. Spending a little bit of extra time here cleaning up any of the residual lens cortex. Being very cautious. Okay to do a YAG laser at another point in time in the future, but let's not damage the bag anymore. So there's the cohesive viscoelastic filling up the capsular bag. Now lens placement. You can do a single piece of lens. You can use a 3-piece lens. The patient's getting a monofocal lens, and we're going to opt for the single-piece design. And so we'll place that single-piece design here in the capsular bag, and we're going to orient the haptics so that they're in the area of greatest overlap of that capsule. And that's going to be very helpful. So making sure we put this in nice and slowly. Here comes the lens. Delivering it in there and opening the haptics, and we don't want to rotate the lens much. Keep it right there, and there we have a nice overlap. You can see there nasally, the top part of your screen there. That looks fantastic. Now, we may have to trim the capsule a little bit more. So we're going to go back in here, take out our viscoelastic. It looks pretty good, but there, just under the phaco probe, maybe there's a little too much of that lens capsule remaining. So we're going to go back and trim that down also. But everything looks pretty reasonable. This patient's going to have a nice outcome. I'm going to put a little more viscoelastic here to give us some control. And we're going to go and try to cut it with scissors. That's hard to access because it's sub-incisional. So just use a cystotome, a bent needle, and let's have a little break there in the lens capsule. And then using our forceps, we're going to just trim this off a little bit, just to have a little bit less overlap. That looks pretty darn good. Now let's finally remove all the viscoelastic, wash out a little bit of lens material, and we can close this case up. So beautiful outcome at the end here, but wow, what an unusual case. I think the big differentiator here is that instead of having a layer of milky intumescent fluid, the whole lens was just super swollen and highly pressurized. And we saw that at the very beginning, prior to even starting. When we touched the anterior lens capsule with the 27 gauge blunt cannula, we could tell that it was a very highly pressurized lens capsule. So we'll do this patient's other eye in the near future, and we'll try a different technique, and we'll compare and see what the differences are going to be. So thanks for watching. Check out CataractCoach.com, our free teaching website. Got a ton of great material. Sign up for our free daily email. We'll send you a case just like this every day. And we've got a section especially for ophthalmology residents. If you're doing your training, you need to have the Cataract Coach on your side.